Good evening, everybody. My name is Vavi Bohbot. I am looking forward to speaking to you this evening on the third part of our master series. This part talks about, well, let's talk do's and don'ts, everything you need to know regarding implant surgery, setup, and all. So we're going to get into just a perfect and simple way to do an implant surgical setup, a septic setup. I went to the simplest of the simplest. A lot of assistants over the years that I've spoken for the ADIA have asked, can we go away from the full blown out setup, which we've taught for many years, and teach a very simple way. So that's what I'll be teaching tonight. And then we'll go through a lot of do's and don'ts and a lot of pearls throughout the hour that we'll be together. If there's any questions, please put in the chat, and I'd be more than happy to answer these questions as we move along or at the end of the conference. And for the ones who weren't here in the last two master programs, well, just wanted to let you know that our programs are designed to be specific and to build upon. Obviously, don't just take 4-part series of master and it's done. There's so much learning to do when you come to the ICOI, to the ADIA, and share your experiences with everybody else, but also learn from the ones that are not only present at the conference, but also obviously the speakers that are there to teach and share their knowledge and their passion in this industry. It inclusive of all the team members. We don't just teach the assistants or the hygienists or whatnot. We teach the entire team. Overlap of education, so everyone is on the same page, is so important. So we don't, obviously the dentists are the ones that are very passionate about this implant dentistry world, but we want to make sure that everybody in the team is as passionate, because patients feel it. And when the patients feel our passion, our conviction, our knowledge, our comfort in the implant world, well, you'll be more geared to get a yes from your patients. Clinically focused, research-based, with experience insight, easily implemented. Any ideas, any tools that we give you are going to be very easily implemented. And hopefully tonight, my pearls, you'll be able to implement them as well. And designed to bring the team together and get the job done. And that's what we want. We want to get the job done. Yes, of course, for the dentist, but especially for the patient. We want the patient to come in and to be assured that they are in the right place, and to be assured that we have the knowledge that we need and the skills that we have in order to deliver the case properly to the patient. So it is all about the team training, and that's what we're going to speak about today. So how can you lower risk of spreading bacteria in your office? Let's start with that. First of all, obviously, is to change into clean gloves. And I know I'm going to say things that are very elementary, but I can tell you after all these years, I've been in the industry for 42 years. I was a dental assistant for about 17 years of those 42. I worked at Dentsply Calc for about 5 years, and the rest of all that, about 21 years, I've been with BioHorizons. And within BioHorizons, I could tell you I've been in a lot of surgeries in the last 21 years, and I have seen it all. And I'm sure many of you who have a lot of experience could tell as many stories than I have. So yeah, changing into clean gloves when touching anything other than the tray and the patient's mouth should be done. So there is no little pinky of opening a drawer, you change your gloves, right? There is no pinky action, which I'm sure we've done it all, including myself. Do not reach into drawers with gloves that have touched the patient or the patient's tray. You're obviously cross-contaminating at this point. If your section falls on the floor, there is no 3-second rule. Replace it and get new clean gloves. Sterilize your gauze. I do see a lot of, when I'm in surgery, we take gauze out of the drawer. It's a no-no. You should have gauze that is sterile when you're working in a sterile environment. I prefer 4x4s and 2x2s, but everybody has its own preference. When opening a non-sterile item, change into new gloves again before touching what has been opened. And then replace the irrigation tubes after every patient's implant. You're not going to believe what I've seen. I've seen offices, unless it is an irrigation tube that is reusable, that's a different story. But the ones that are disposable cannot be wiped down or sterilized because they're going to come out all weird looking. They need to be, it's a one-time use, and one-time use means that after every surgery, they get thrown out and a new one gets ordered. And then sterilize blue wrapping paper and use it for the patient's bib tray and under your handpiece console. And I'll show you that tonight. That is the kind of aseptic that I'm going to show you that's going to make things much just economical and faster as far as setup is concerned. Obviously, I still believe in the full setup, which you will learn at the ADIA, but for tonight, we'll make it simple. So the blue wrapping that we use to cover the cassettes, those are the ones that I use for the patient's bib and the counter to spread my instruments and the surgical kit as well. So here it is. As you can see, we have a big sterilization bag. I go about for 4 or 5 of those cassette covers. I put 4x4s, as I said, that's what I like. 2x2s, a saliva ejector, a surgical section, cotton rolls, and whatever else you think that you might need that actually can be sterilized would be in that bag. And it would look like this. Once it's sterilized, I am ready to set up. And so I'll play the video. And so I open the bag with clean gloves, obviously. And as I open it, I spread it on the counter. And now, instead of getting into it, I actually will then open all the stuff that I need to use for surgery and dump it in the middle of the sterile environment, right? You'll see me continuing with a bunch of instruments that I rolled up in a cassette cover as well. And I will just open it up and throw it, or slowly, oh, I'll go into the next slide, I apologize. Go. And so open it up and slide it into, or just open it up and leave it there as well. There's no problem with that as well. I have a tendency to want everything in one place so that it's nice and organized for me. Once I do that, I'll change my gloves. You don't see that, but I am changing my gloves. And then once I have clean gloves, because remember, I touched everything that was non-sterile. I'm going to change my gloves, put on clean gloves, and at that point, I'm going to now take out things from this area. This is where I'm going to set up my instruments and my surgical kit as orderly as we can. Once I've organized it, very often I'll put all the suturing away from me. I don't need it right now. I'll put the retractor close to me because I'm going to be retracting more. And then the order that you and your dentist have agreed on for surgery. Once that's put there, I'll put my 4x4s, I'll put 2x2s, my section, everything on my side, obviously, because I'm going to be the one using it as an assistant. And then I don't want the patient to see all the shiny, pointy instruments before they get into this procedure. So I'll use one of them to cover the instruments, and most probably that's the one I'm going to use for the patient's bib when they come in, or the one that I put extra, depending what my needs are. So I'll spread as far as I can. I'll take the cassette, and as you can see, I'm going to cover the entire counter with the cassette there, and off I go. Obviously, there is still the motor to set up as well, which I'll talk about in a minute, but that's kind of like a simple setup, easy to go, easy, fast, for a single implant placement, 2 on the bottom, something that doesn't take too much time. So, you should know this about dental implants, certain things, certain aspects that I'm going to talk about. Implants are tiny orthopedic devices for the patient. And I know that a lot of times, obviously we all call them implants, but they are orthopedic devices that go through quite a process for them to be in a sterile environment. And so all of a sudden we open them, and very often, even though we're gloved, but it's still contamination, we touch the implant and we shouldn't be. We should keep it in that sterile environment. So implants go through a sterilization process that is very meticulous before sending it to the office. Implants are FDA approved to be in only one thing, and that one thing is bone, not your gloves, not the patient's bib, not anywhere else, but only the bone. An implant should not touch anything other than the bone, implant driver, cover screw, or healing abutment. And implants should not be touching also the suction nor the gloves. So be careful with that, because there's a lot of saliva, a lot of contamination that can happen when we touch our suction with the implant. So when we're ready to place the implant, we should actually not suction dry, not suction dry the osteotomy. We should just dab it with a 4x4 or a 2x2 that's been hydrated with saline, and then just dab the area and retract obviously properly. Make sure that it's well isolated when the dentist is placing the implant in the osteotomy. It doesn't stop there. Sterilizing your kit is also a specific way of doing it as well. No chemicals. Don't put it in chemicals. Don't use the wipes that we wipe our counters and our chair by wiping the drills. That's actually going to rust them. That's going to remove the coating, the protective coating that manufacturers put on the drills. And the next time you sterilize it, they're going to start rusting. When to use a Dixie cup? Not for bone, not for membrane. A Dixie cup is not sterile. If you want to put things that you're going to chuck or throw out, then that would be the case. A 2x2 full of blood, a 2x2 full of debris that you want to get rid of, a tooth that you just removed can be put in a Dixie cup. But something that you're going to put back into the mouth should not be in a Dixie cup, because that is not a sterile environment. When to use a sterile and glass container. Saline water in a glass container, obviously that glass or metal container, depending on where you buy them. Obviously make sure that it's medical grade. But once it's sterilized, obviously anything that's going to go in there can go back into the mouth. So bone, hydrating of bone, hydrating of a membrane, hydrating of a 2x2 or a 4x4. Again, think of it. Anything that is non-sterile, that is never going to go back into the mouth, can go into a Dixie cup. That's not a problem. But anything that goes back into the mouth should go into a sterile glass or metal bowl. Don't put in the ultrasonic. It's not necessary to put the drill bits into the ultrasonic, because I'm going to say not to put in the ultrasonic, because I don't know what kind of solutions every office uses. So very often what we'll do is we'll actually put the drill bits into saline water in a sterile bowl. And I'll show you the step-by-step how to do that. Make sure it's dry before autoclave. So all the drills should be dried with a 2x2, put back into the drill kit, and then obviously autoclaved. And account for all the pieces. How many times we go into surgery and oops, one drill is missing, the driver is missing, or some things are out of place, which could be even more dangerous. So make sure that your drills are accounted for. I would tell you to and it's not to point the finger, it's just to be sure of who was responsible to put back the drill bits. Maybe that person put that drill bit separately or took it away from the drill it because they're thinking of ordering one that's going to come the next day. Whatever the reason is why we're missing a drill could be a valid reason. But if you put your initial, then we know who to consult when something is missing in the kit. Well, let's go into the amazing pearls. So here is the pearl for the drills. So your dentist goes through all the drilling sequence. As they go through the drilling sequence, you could take the drill and put it into the bowl. Just dump it into the bowl that is now full with saline water. And what's going to happen is the drills actually accumulate bone. And that bone is actually going to detach itself in the bowl from your drill and kind of drop to the bottom of the bowl. And as you continue your osteotomies, continue dropping those drill bits in the bowl. Once you're done with your osteotomy, take the drill bits out. Don't take for granted that all the bone was taken off by the saline water. Make sure you check it before sterilizing it or putting it back into the kit. You'll see that there's going to be a lot of chips of bone at the bottom of the bowl. You're going to take a 2x2 and open it up into a 4x4, and that becomes like a mesh. You put it onto the bowl, as you can see here. And the next step, you would use a suction, and that suction will never suction the bone. It'll actually only suction the extra water that's in the bowl. And that's what you get at the end, is a little bit of saline water with the bone that's been accumulated by your drills. And as you can see, it's quite a lot of bone. So sometimes we don't have to open up a 0.5 cc or a 1 cc of bone. Sometimes, and again, it depends on the bone density and what bone quality you were in. But very often we can accumulate quite a lot of bone from the drill bits. And so I'll let that video go. Here you go. And you take a 2x2, pick up the rest of the saline water. If you need to mix, if you need more bone, you could crack open a bowl of mineros or whatever bone that you use in your office and mix it to that before you pick up all the bone. Let it hydrate in there for about 30 seconds to a minute. Mix it up and then pick up all the saline water that's left over. So that's a great way, because now you've got vital bone that's actually mixed with your allograft. And that can definitely activate the bone growth in the osteotomy or wherever you're grafting. Another trick is, I'm giving you a whole bunch of pearls from over the years. Another trick is when we drape, if you do that and you drape the suction hose with a sleeve, we used to just put the tip of the hose at the tip of the connection of the suctions and tape it. But we've noticed over the years, as we assist, that tape comes off and everything just unravels, right? So this is a nice new way of doing it. Pierce through, there we go. And then the rest of it, you'll tape it with the tape that you've kept from the roll itself and secure it. And then that way, that envelope or sleeve will never unwind, because it's been punctured and it's going to stay there throughout the surgery. Sorry about that. The other thing is, if you're sitting down in surgery, another great way, I'm always afraid when I have to put back the suction and that sleeve is on it. Because of the sleeve, sometimes it doesn't hook properly. And many times I've seen it fall on the floor. So what I'll do is I'll sit, and my gown is actually draped on top of my seat. I'll drape it on top, so I'm kind of becoming one with the chair. And I will take my scrub, my gown, and actually pin down the suction with it with a hemostat. And so now the suction becomes one with me. I can just drop it on the patient's chest. It's not going to slide off. It's part of me. It's not going anywhere. So another pearl. And here is a better vision of it. As we're sitting down, you could actually just pin it to your gown, and you could make it as long as you want, or accessible also to your dentist in case they want to grab it while you're mixing or doing or hydrating or cutting or preparing something. They can use it as well, but at least nobody needs to go towards the back to put the suction back into its place or take the risk. If you do a full aseptic technique in the gown that comes for the patient, the drape that comes with the patient, there's also the Velcro part that's in the middle of the, I'll call it the gown bib/bib. And that also could be utilized to secure the suction, leave it on the patient's chest. Very often I'll do it with a saliva ejector, because once in a while, either myself or the dentist will grab it to to eliminate some of the increased water or saline water that's in the mouth. The other pearl that I can give you is when you're doing a sinus elevation or when you need a suction with precision. The best way to do it with precision is the way I'm holding my suction right there. I have one hand, which is my right hand, on the top of the suction with very much control. But then what I'll do is I will put my fingers on the patient's chin and I will hold the tip of the suction with my two fingers, and that suction is going nowhere. Even if the patient moves, I'm in total control of that suction tip. Very important when you're doing a bone grafting procedure, and extremely important when you're doing a sinus elevation. You want to make sure that you are in complete control, that you're not sliding into the sinus and, God forbid, pierce the sinus. When we use 2x2s or 4x4s, obviously sterile 2x2s or 4x4s, we hydrate it or we pour some water, some saline water from the bottle directly onto the 2x2s and 4x4s, and we squeeze them to make sure that they're not wet, but just damp. But if you squeeze it, and now you're in surgery, you squeeze it, you put it on the table onto your counter, and you have like 5 or 10 of them bunched together. And now you're in the middle of suturing or doing a bone graft and you've eliminated the suction, and all of a sudden you need just one 2x2, just one or 4x4. And you go with the college pliers, and as you pick it up, 10 of them come with you, and that's not what you wanted. You only wanted one, and now you're freaking out because you only want one. So the best way to do it is squeeze it and then lay them, fan them, so that you're able to only use one at a time. And if you want another one, you could pick up another one, but to have 10 of them coming at the same time, you're retracting, you've got one hand that wants a 2x2, and now with your hand that's retractor, trying to remove the other 9 and only use one. So I would suggest, as you sit in surgery, before you even start, patient is numb, you're ready to get into your surgery, take a whole bunch of 2x2s or 4x4s or a mix of both, soak them with saline water, squeeze them, fan them, and they'll be ready for you throughout the surgery. A foramen, a mental foramen, just wanted to show you, here it is right there. Not as thin or delicate as we think it is, obviously be careful, but they're not as delicate as we think they are. So obviously when we're doing an all-in-X, your dentists will learn to expose those. They are very important to be exposed. We need to know where they are, especially when we're doing freehand surgery. So they'll expose them and count a certain amount of millimeters towards the midline to make sure that they're far away from the mental foramen when they start their osteotomies. Beautiful to look at. A pearl of a lip and cheek retractor. If you're going to use a Minnesota when you do fixed full arches, it's okay. But now your dentist is doing an osteotomy on the left side, then you're following with the Minnesota. Oops, I'm going to on the right side. Then you have to follow with the Minnesota, and you're going back and forth. And now you lose the lip, you lose the retractor. It becomes a little bit messy, and everybody gets frustrated, especially if it's a long surgery. A lip and cheek retractor are great instruments. They are actually just like a U shape. They go into the lip, and you could retract, and you could see that my hand is underneath the patient's chin. The patients love it when I do that. It gives them a place to rest. I'm in control of their jaw. They don't have to hold it for us in amount of sometimes hours of surgery that we go through. And as you can see, there's also a tie back that's in the buccal. Very often we see a tie back in the lingual, which is absolutely necessary, but I love the dentists that do me a tie back in the buccal as well, so that when I retract, everything follows with me. I don't have to worry about that buccal flap as well. And you can see a better picture here. There's a tie back in the lingual, but there's also a tie back in the buccal. And so again, as you're pulling and moving towards the chin, everything follows you. So as an assistant, I use a lip and cheek retractor, and then all I have to do is have my suction ready, and I'm in full control of what's going on in the mouth. Maybe a saliva ejector at the back of the mouth wouldn't be a bad idea if there's a lot of water going on, but very often I can keep control with the lip retractor and a good suction in my mouth, in my hand. And here it is again. Little trick I learned from a dental assistant in one of the institutes. This is actually me a little while ago assisting four-handed suturing. And I had to figure out a way to keep the scissors not far, but I didn't want to keep it too close because it could be dangerous as well with the patient's hands. Sometimes they fly all over the place and they can cut themselves. So this assistant was brilliant. What she did is she would put the sutures on the top of the bib. Obviously, this is sterile. She would put it on top of the clip. So they weren't clipped in, they just hooked on. And I found that brilliant. So any pearls you guys, everybody has, I'd love to hear from you. Send me some pictures. You'll have my email at the end, and I'd love to hear other pearls to share with everybody else. I think that I've learned over the years and from the beginnings of working in the implant world is sharp things. Sharp things are very dangerous on the surgical counter. Especially if you've got a few hands moving around. Sometimes you have a non-surgical assistant also assisting you, and it could become a dangerous area. And so very often when we open the surgical or the drill kit, we take the lid and we just put it away and we don't use it at all. Well, I use it, and I've been trained to use it as a sharp area. So anything that is sharp, anything that is small, anything that I have to worry about goes into that lid. So that's what it looks like. I've got my blade, I've got my needle. If I have a cover screw, I'll put it in there. Whatever I have that I got to pay attention to at the end of surgery or during surgery will absolutely go in there. Sideline of just knowledge of the hand pieces that we work with when you have a 20:1, a 1:2.7, and a 1:1. Very often I see that in the industry, we don't really know the difference between those hand pieces, what they're used for, and how to program the console, the motor, in order to work with these hand pieces. So the 20:1 is a latch type. That's what we know what latch type means. It's a latch type. It's a handpiece that greets drill bits that have a latch. The console, the motor, the brain of the motor usually will go at 40,000 RPM. That's the max of the speed of regularly the motors go at. And when you plug in a 20:1, what the 20:1 will do is it'll divide the 40,000 RPM into 20, which will equal 2,000. So if you want to decrease the speed instead of 2,000 to 1,000, then that 40,000 needs to go down to 20,000. 20,000 divided by 20 will be 1,000, and so on and so forth. The 1:2.7 is the high-speed handpiece. So we all know what a high-speed handpiece is. And the high-speed handpiece will actually multiply. So it'll take the 40,000 multiplied by 2.7, it'll go at 108,000. It's rare that we go at 108,000 in the implant world, but sometimes we'll go at 50,000 RPM when we do sinus fenestrations with the 1:2.7. So in order to go at 50,000, you would reduce the 40,000 to 19, 18, around there, 18,000. And that number multiplied by 2.7 will give you approximately 50,000 RPM. And then the 1:1 is the straight surgical handpiece that we're used to. And the straight surgical handpiece is a 1:1. It'll multiply by 1, whatever speed you're at. I would recommend that you stay at 40,000. That handpiece, you want to go at 40,000 RPM because very often that's the handpiece that's going to level down the bone and you need to move. If you go slower than that, it might take a long time before you complete the job. Little pearl that I saw just a couple of years ago, actually, that fascinated me. Back in the days when somebody would gag, when I was an assistant back in the 80s and 90s, we would actually put salt on the palate, and it would work to a certain point. But it obviously, with the saliva and everything, they'd gag again, and we'd have to put salt again. Not the most amazing stuff for the patient. It's the taste of the salt would not be fun for the patient. So I walked into this operatory room while a course was going on, and I see an endophile stuck in the patient's chin. And I'm like, what? I don't understand what's going on here. And obviously, the patient is numb, and they put the endo file in there. And the minute, just to show all the dentists that were obviously learning at that course, the minute they took off the endo file, and they played in the and he was a big gagger, and they played in the patient's mouth, the gagging reflex came back. The minute they put back the endo file exactly in the middle of the chin, and they played in the patient's mouth, gagging was gone. So I was very happy to be there at the right time, at the right place, to share with all of you this amazing little pearl. Another one that I caught also in a surgery, I don't know if you could see it, but here it is. What do you do with your needles? You could put it in the lid, like I mentioned to you, but sometimes with the sutures, they kind of get mixed up and then they go onto the surgical table or counter, which we don't want. So this assistant actually took the needle. If you're working with a cassette system, what she does is she actually punctures the rubber of the cassettes, and that gives her more stability for her. She knows where they are at all times, and if she needs them, she can get them back. Also, by stabbing the rubber, does not remove the sharpness of the needle. So great little trick that I learned from the assistant that day. Scissors. Avoid opening packages with your suture scissors. Do not do that. Been there, done that. I have done that. But it is not to be done. The minute you do that, you go to cut sutures with scissors and they will not cut. They will actually slide off the tip. So make sure that suture scissors are made for sutures. And scissors that are bought that are much cheaper scissors, you can use them for everything else that you need to open. Anything that has a hinge, whether it's a needle driver, a hemostat, scissors, should be sterilized in an open position. If you don't have a cassette system, it's not the end of the world. Open it up and put it into a bag. As long as it's open, it's super important. If they are sterilized in a closed position, then there's going to be a humidity that's going to be locked in those hinges. And as you continue sterilizing it that way, there's going to be a little bit of a very thin film of rust that's going to be locked into that hinge. And eventually, I'm sure you've lived that, where your dentist is trying to cut, or you're trying to cut the sutures with the tip of your scissors and nothing happens because you've got that little toying around, or that little jiggle, I could call it, the little jiggle that happens with the hinge, and everything becomes loose, unfortunately. To sterilize a whole bunch of instruments in a bag doesn't make them more sterilized. Unfortunately, when you put a lot of it, and sometimes accumulation, which is a little bit too much of instruments in the bag, when you put it into the sterilizer, you want the humidity or the dampness or the water, the vapor, to go through the instruments. And if they're bunched too much together, well, the sterilization will not be effective. And then we're rushing, right? So we take the bag out, we kind of cut the dry part from the sterilization, which is not to do as well, because know that when there is a humidity, it actually opens the pores in the bag and lets the sterilization happen within the bag. The drying cycles actually seals the bag. So when we speed up the drying cycle, the sealing isn't being created and it's not sterilized, right? Everything, all the pores are open. And then what happens, because it's wet and the pores are open, instrument starts to pierce through our bag. So leave the sterilization, go from beginning all the way to end. And if you find yourself stopping the sterilization more often than not, then ask yourself, do we have enough instruments to be able to go through the morning? And if you see yourself stopping it too fast, maybe you just don't have enough instruments, and it's things that you need to think about. You should not also remove blades with your needle driver. A needle driver is made for suturing. It is not made to remove blades. The minute that you do that with a needle driver, you unbalance the needle driver. Now the dentist is trying to grab onto the needle and it twirls around. That's because the calibration of the needle driver is gone. So there are a lot of different tools out there to be able to remove the blade in a very, very safe way. One of the ones that I like to use is, and I don't work for you, Freddie, but there's a great little tool that I like to use, which you could put in all your cassettes. It's not an expensive tool, or obviously any other tool. Just make sure don't use your needle driver. And scissors, obviously, why is it very important to use sharp scissors? Because you don't want to, it becomes very sensitive to the patient when you don't have sharp scissors. What happens to us is that we tend to pull on the suture to be able to get a little bit deeper to be able to cut the sutures. What we're trying to do, what we should do is obviously keep the scissors for the scissors. Don't open anything else with the scissors. That will keep them sharp, and then you could use the tip and also sterilize them in an open position, as I mentioned just prior to that, and that will keep the tip nice and sharp. And when you take off, when you cut the suture, it'll be much less sensitive to the patient. What about a college plier? Can we do everything with a college plier? Absolutely not. A college plier is just meant to grab something out of a counter, out of the drawer. It's meant to grab a 2x2 off the counter. Not much else. It should not be used for suturing. An Adson should be used for suturing. An Adson should be used to pick up the tissue. The serration of the Adson is much more delicate for the tissue than a college plier. A college plier is much too aggressive. You're going to slip and slide, and especially when it comes to a very delicate tissue, you will tear the tissue. So corn plier could be used as well. A corn plier has little holes at the tip. When you're trying to suture a tip of a papilla, sometimes your dentist will slide to try to grab the tip of the papilla. This is a great way, I'll show you. The needle will go through the corn plier while it's holding the tissue. Here's another great image right here. You could see that we're holding the tissue and very safely, and it's a tiny piece of tissue, but the needle will follow those holes and go right through without tearing the tissue. So it's a beautiful instrument to use when you're doing really refined suturing around very thin tissue or papillas. How do we put our gloves? If you're using sterile gloves, obviously this is not the case if you're using gloves, clean gloves out of a box, and there's nothing wrong with that as well. But if you are going to use sterile gloves, this is the way to put them on. You open up a pack, obviously you've washed your hands. You use the inside of the cuff, it's going to get contaminated anyways, and put your hand through. And then the other hand, don't do what you just did, what we just did, it actually goes into the cuff because we want to keep it sterile in a sterile environment, and then put your hand through. Very often people will hold the tip of it, but then the thumb will get contaminated with your skin. Off it goes, and off it goes, and we're ready to go. What about your hand pieces? Do you wash, do you clean it? Do you disassemble it? Do you know how to do it? If you're using an SK or you're using W&H or Aseptico, there are many motor companies or handpiece companies that have little great videos on YouTube that show you step by step how to disassemble your handpiece and how to put it back in place. So make sure, I mean, this is just like a couple of months later, and I disassembled this handpiece and saw this disaster. So make sure that you disassemble the handpiece, wash it under soap and water. There's no problem with that under soap and water, but make sure that you dry it really well before assembling it and then oiling it, right? I can't tell you the frequency that it needs to be done because I'm not sure what frequency of surgeries you do in your office, but it definitely should be done frequently. It doesn't have to be done every day, but at least once a week if you do a couple of surgeries or you do surgery every day. Another pro that I can give you is, we disassemble this in 4, 5, 6 pieces, depending on the handpiece, but you'll never disassemble it in 10 pieces. Those are the technicians of those companies that will do that. So very highly recommend that you do that maybe twice a year. Again, depending on the frequency of implants that you place, once a year. Pick the time when you're on vacation, let it go for a week or two, let them disassemble it, tune it up and clean it up and replace all the parts and pieces or some pieces that are broken or defective and put it all back in place. Remember that you're depending on that handpiece in order to place implants. So if you're going to depend on it and you do a lot of implants, first of all, I hope you have 2 handpieces, if not 3, but definitely send it in for a tune-up. It should look like that once it's cleaned, right? So whether it's the straight hand piece or the contra angle, whichever one it is, and again, it depends the company that you use at your office, but there are great YouTube videos that you definitely need to look at, or have a technician come over or an implant manufacturer rep come over and share with you how to dismantle the handpiece. Easy cleaning and can be fully dismantled without the need of additional tools, that's for sure. And please always obviously refer to the IFU of, here in this case it's W&H, but any other companies that you deal with as far as the motors are concerned. I did speak of it in my first couple of slides, but I wanted to show you that the irrigation tube, the disposable irrigation tube, are one-time use and should be thrown out after every surgery. Please don't keep them. Also, the irrigation clips that go onto your hand pieces, at a certain point, they are going to get loose because obviously we sterilize our hand pieces and they will get loose. So there is a way to re-buy them. You will sometimes, I've seen it in the industry where assistants will call me, they're just starting a surgery and they can't find that little tip. Well, sometimes when we remove the irrigation tube, the tip comes with us and we throw it in the garbage. We're busy, we haven't looked at it. It was really, really loose. As we took out the irrigation tube, it got chucked. Next week, I'm in surgery and oops, I have no irrigation tip. So I would recommend that you always have an extra one stored, sterilized, ready to go. I would also recommend that before you throw out the irrigation tube, pass your hand from top to bottom, making sure that no tip has been left behind. And make sure that you also order the right tip for the right handpiece. I have seen that as well. So there are charts. In this case, it's W&H. Again, there are charts for every company out there that will assist you in what tip goes with what handpiece, whether it's a straight handpiece or the contra angle. There's also these little black clips that go along the motor cable to keep the irrigation tube in unit with the motor cable. Those will dry off, those will break, and there is a way to buy them as a refill, packs of 5, usually it comes. To put in the irrigation tube through the motor, this is an older motor. I wanted to show you an older motor because I know the new motors, they have them on YouTube now, but this is the older motor. So if you do have that in your office, make sure that this ledge that's right here is outside the drawer, and make sure that the other ledge is on the outside of the drawer as well. If it's on the inside, as you see here compared to here, if you don't see my pointer, I think you do, well, the left picture with the red cross instead of the one on the right, and you close a drawer like that, you'll still be able to do your surgery and you'll still be able to have water coming out of the irrigation tube, but the problem that you'll have is a big puddle on your counter as well. So if you do have a big puddle, ask yourself, how did I assemble the irrigation tube? And are those two notches on the outside of the drawer, or is one of them on the inside? So having, sorry, I'm gonna go back here. So not little, a big surgery that I witnessed about a year ago. And it's something that I have never seen of my 40 years of experience. Maybe one of you have, but I have not. And it was quite, I'll call it aggressive way of doing a surgery, but quite effective as well. And I'll share this with you right now. So traditionally, what do? We take out the teeth, we flap, we level down the bone, and we place the implants. And sometimes removing the teeth is a challenge. Doing a flap is a challenge. And removing the bone takes a lot of time. And a lot of times I have the bone and the blood all over my gown, right? And everybody else's gown. So in this case, what the dentist did is they left the teeth in place and they just did a full flap. And they measured how much bone they needed removal in height in order to give this patient 2 implants. And eventually they were going to have another 2 implants. Financially, at that time, they just wanted 2 implants. And so as you can see, they took the straight handpiece and they cut the part of the jaw with a straight handpiece instead of removing the tooth one by one. As you can see, these were teeth that would have been very difficult to remove. And they keep going and they keep going. And here we go. I hope everybody is good watching this.
Et voila.
There we go. You hear a little bit of French because I'm from Montreal, and that was a big surgery in Montreal that we did. So it's removed. That was kind of weird to see that on the gauze the first time. I've gotten used to it since then. But amazing. The extraction was done all at the same time as removing the bone. There was no blood on me. There was no blood on anybody else. Quite an amazing technique. And the bone is leveled in 2 seconds. So how fast, obviously anatomically, please know what you're doing. Please know where you're cutting. I'm not a dentist. I'm not here to teach you how to do that, but just another pearl of another way of removing a lot of time off the surgery by doing this technique. 2 implants were placed. As you can see, I'm using the lip and cheek retractor, which makes it very easy for me to be able to assist the surgery. 2 implants were placed, a cover screw was placed, and everything was sutured up, and a denture was delivered. And the healing would take about 4 months before we load those implants. So great surgery done. Just a little bit of pearls also. I see a lot of, when I go into offices, a lot of wrinkled scrubs, and I understand that we maybe rushed the night before and we got them off the dryer, put them in a bundle of clothes, forgot to fold it or iron it or whatever you do with your scrubs, and the next day you have wrinkled scrubs put on. Again, there's nothing wrong with that, but when we're trying to sell a $25,000, $30,000, $10,000 treatment plan to a patient that sees us in a scrub that's wrinkled, might not go as well as somebody that is nice and neat and clean and ironed and ready to receive. It looks like we've taken the time and the importance to show up that day in surgery in a well-fitted uniform. And if you wake up in the morning and you don't feel like you're in the right place, well, maybe it's something that we need to think about, right? And it happened to me 17, 18 years into my dental assistant career. I was doing really, really well up to the year 12, 13. I assisted really high-end dentists, did a lot of high-end surgery, had my kids, came back into the industry, and things shifted in the industry for me. And I saw myself not liking what I was doing, and I needed to have a change. If I knew what I knew today about implant dentistry, I would have become an implant coordinator. That's for sure. That would have been the career for me. But back in the 90s, we didn't place as many implants as we do today. And so I had to find another path in my career because I definitely did not want to abandon my amazing dental career. Again, today there's so much technology, there's so many things we can specialize in, get better at, perfect in. So enjoy your career, love what you're doing, keep learning, keep pushing, and become better every day. And it is showtime. And I don't want to say just implant dentistry. Obviously, tonight we're talking about implant dentistry. And it is showtime. When you wake up in the morning, when you come into the office, your attitude, your intention, your focus has to be to the highest point in order to be attentive to the patients that speak to you about what's going well with their whatever's going on in the mouth, but also the challenges that they have to live with, as we spoke to about on the session 2 that we did a couple of weeks ago, about the challenges that they're going through. Well, if you're not showtime on and completely on, you're going to skip some pointers, some pearls, some things that the patients share with us that would be able to bring them to saying yes. I'm going to say, if you're physically tired at the end of the day, that's normal. But if you're not mentally tired at the end of the day, something went wrong. Maybe we weren't as focused as we should have been. You very often, when we get a lot of yeses at the end of the day, and if you rewind and remember, those are the days that you were probably more brain tired. And that's because of the focus of trying to listen to every word the patient communicates with you to be able to try to bring them to what would be the best treatment for them. And at the end of the day, say yes to implants. I thank you for your time. I thank you for these last 2 sessions. It's been an honor of mine to share my passions, my knowledge with all of you. Please email me at vavi11bobot@gmail.com. I'm very accessible and would love to hear more. Even if you have some pearls or some challenges that you want to share with me, I'd love to hear from you. Have a great evening.